Welcome to the deep dive. Today we're tackling a really important topic, something that touches a lot of families, familial arteriosclerosis.
That's right.
We're going to explore how our genes, what we inherit, can really significantly shape our risk of atherosclerosis.
Which is that plaque buildup in arteries, the root cause of so much cardiovascular disease.
Exactly, and we know you want to get a good handle on this quickly without feeling totally overwhelmed by the science.
So our mission here is really to pull out the crucial insights. How do these inherited factors actually influence atherosclerosis and related conditions?
We're drawing on some solid material chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Good source. Our goal is to give you the essentials, the core connections between genetics and heart health.
Okay, let's dive right in then. Can you break down atherosclerosis in simple terms? What is it exactly?
Sure. So imagine your arteries are like smooth, flexible pipes carrying blood. Atherosclerosis is kind of like rust and gunk building up inside those pipes. That buildup, the plaque, makes the pipes narrower and stiffer.
Which means less blood can get through, right?
Precisely. It reduces blood supply to your organs.
And this plaque, this gunk, it's not just one thing, is it? What's actually in it?
No, it's quite a mix. There are fatty substances, cholesterol, which we'll definitely talk more about, but also things like cellular waste, calcium.
Calcium, like in bones.
Yeah, it can deposit in the plaque, plus fibrin, which is involved in clotting, and inflammatory cells, platelets. It's a whole inflammatory process, really.
And it can happen anywhere, not just the heart arteries.
That's a key point. It can affect any artery in your body. Brain, legs, kidneys, everywhere.
So while cholesterol gets a lot of the headlines, it's clearly more complex than just that.
Absolutely. Atherosclerosis is multifactorial. You've got inflammation, oxidative stress, that's like cellular wear and tear, the lipid deposition, yes, but also, crucially for today, genetic predisposition.
Now, Rutherford's brings up a really almost novel idea about how this might even start. Something about repair.
Yes, that's quite interesting. It touches on the idea of impaired arterial repair. Our bodies have these cells called endothelial progenitor cells, EPCs.
EPCs, okay.
Think of them as like the body's little road crew for fixing potholes in the artery walls.
Ah, repair cells.
Right. And the theory is if this repair system isn't working optimally, maybe due to genetics, then small injuries to the artery lining don't get fixed properly.
And that unrepaired damage could be the starting point, the seed for plaque.
Exactly. Like those potholes, if they aren't filled, they just get bigger and eventually cause problems. It could be an initiating factor.
That's a really powerful concept. Failure to repair kicks things off.
Yeah.
Okay, let's zoom in on cholesterol now. It's a name everyone knows in this context.
Right. And cholesterol itself isn't inherently bad. It's a fatty substance we actually need for making hormones, building cells, digesting food.
But too much of it in the blood is the problem.
That's the issue. Elevated plasma cholesterol levels significantly increase the risk of it depositing in those artery walls, contributing to atherosclerosis.
And our bodies make their own cholesterol, don't they? It's not all from diet.
Correct. Most of our cells can synthesize cholesterol. There's a key enzyme that controls how fast this happens, HMG-CoA reductase.
HMG-CoA reductase. That sounds familiar. Isn't that what statins target?
Precisely. That's the enzyme statins inhibit. And interestingly, doctors can sometimes measure a related compound, mevalonic acid, to get an idea of how much cholesterol the body is churning out.
Okay, so cholesterol is made. It's in our blood. But how does it travel? It needs transport, right? That's where lipoproteins come in.
Exactly. You can think of lipoproteins as the delivery trucks for fats, including cholesterol, in the bloodstream.
Like taxis, maybe?
Taxis, trucks, yeah, they ferry it around. The two main ones people hear about are LDL, low-density lipoprotein, and HDL, high-density lipoprotein.
Ah, yes, the infamous bad and good cholesterol. Can you unpack what they actually do?
Sure. LDL's main job is delivering cholesterol from the liver to the cells throughout the body that need it. It docks onto specific receptors on cells, the LDL receptors, or LDLR drops off its cargo, and then it's usually broken down.
An HDL. The good one.
HDL works more like a scavenger. It goes around collecting excess cholesterol from tissues and transports it back to the liver, where it can be removed from the body.
So it's like reverse cholesterol transport.
Exactly. That's why having higher levels of HDL is generally considered protective against cardiovascular disease. It's helping clear things out.
This whole system really sets the stage for understanding conditions where genetics throws a wrench in the works, like familial hypercholesterolemia, FH.
FH is a perfect and quite dramatic example. It's typically a monogenic condition caused by a defect in a single gene leading to extremely high levels of LDL cholesterol right from birth.
And the consequences can be severe, right? Early heart disease.
Very severe. People with FH can have dangerously high cholesterol and face a much, much higher risk of developing atherosclerosis and having heart attacks or strokes, often at a startlingly young age.
Are there visible signs, things someone might notice?
Sometimes, yes. There are some characteristic, though not always present, physical signs. Tendinous xantomas are one. These are fatty deposits that can form on tendons, quite often on the Achilles tendon or knuckles.
Yeah, lumps on the tendons.
Right. Also, arcus cornea, which is a whitish or grayish ring around the edge of the cornea, the clear part of the eye. It can occur with age normally, but seeing it in someone younger can be a clue.
And what about the eyelids?
Yes, xanthelasmic. Those are yellowish, slightly raised plaques of cholesterol that can appear on or around the eyelids.
So what's the actual genetic problem in FH? Which genes are involved?
Okay, so the most common forms are autosomal dominant. That means you only need one faulty copy of the gene from one parent.
Right.
The main culprits are mutations in the LDLR gene. That's the gene for the LDL receptor itself.
The docking station.
Exactly. Or mutations in the ApoB gene. ApoB makes a protein that's part of the LDL particle, the bit that actually binds to the receptor.
So the key doesn't fit the lock properly.
Kind of, yeah.
Yeah.
Or the lock itself is broken, LDLR.
Mm-hmm.
Then there's the PCSK9 gene.
PCSK9. That one's become quite well known recently because of new drugs.
It has. Normally, PCSK9 helps regulate the number of LDL receptors by marking them for destruction inside the cell. In FH, you can have gain-of-function mutations that make PCSK9 overactive.
So it destroys too many LDL receptors.
Precisely. Fewer receptors on the cell surface mean less LDL gets cleared from the blood. There's also a rarer autosomal recessive form involving the ARH or LDL-RIP1 gene, which helps the receptor function inside the cell. But the bottom line for all these is impaired LDL clearance.
You mentioned dominant inheritance. People can inherit one faulty gene copy, heterozygous, or two homozygous. How different are those?
Very different in severity. Heterozygous FH or HeLFH is relatively common, maybe 1 in 250 people. Untreated, it leads to about a 20-fold increased risk of coronary artery disease. Onset is earlier too, especially in men.
Still a huge risk increase.
Absolutely. But homozygous FH, HoFH, where someone inherits faulty copies from both parents, is much rarer, maybe 1 in a million, but devastatingly severe.
How severe?
We're talking extremely high LDL levels, often developing severe heart disease by their mid-20s, sometimes needing bypass surgery or facing death in adolescence. They can also get aortic stenosis, a narrowing of the main heart valve.
Wow. Okay, let's go back to those LDLR mutations. You said they affect the receptor. How exactly? Are there different ways it can go wrong?
Yes, researchers have actually classified LDLR mutations into 6 different classes based on how they disrupt the receptor's life cycle. It's quite elegant in a way.
6 classes. Like what?
Okay, class 1 means the receptor protein isn't even synthesized properly. Class 2 means it's made, but it gets stuck inside the cell and can't get transported to the surface where it's needed.
So it never even gets to the docking station place.
Right. Class 3 means it gets to the surface, but it can't bind to LDL effectively. Class 4, it binds LDL, but it can't get pulled inside the cell, a process called internalization.
Okay, 2 more.
Class 5, it gets inside with the LDL, but it can't release the LDL properly and get recycled back to the surface. And class 6 means it gets back to the surface, but it doesn't end up in the right location to effectively capture LDL.
So lots of different ways for the system to break down. But the result is the same high LDL in the blood.
Exactly. Impaired LDL uptake by the cells.
And what about the other FH genes, ApoB and PCSK9? How do their mutations cause trouble?
With ApoB, the common issue is a specific defect, sometimes called familial defective ApoB100 or FDB. The mutation changes the part of the ApoB protein that the LDL receptor recognizes.
So the receptor is fine, but the LDL particle itself can't dock properly.
Correct. Fewer mutations have been found in ApoB compared to LDLR, but they lead to similar problems. Interestingly, someone homozygous for FDB might have cholesterol levels similar to someone heterozygous for an LDLR mutation.
And the PCSK9 gain-of-function mutations, we touched on that.
Right, those lead to increased degradation of the LDL receptors. More PCSK9 activity means fewer receptors available. It's like having someone constantly removing the docking station.
Got it. And you briefly mentioned APOE and ARH.
Yes, mutations in those can also cause forms of hypercholesterolemia, sometimes recessive ones. It highlights that multiple genes are involved in this pathway. And importantly, even among people with the same FH mutation, how severe it is can vary.
Why is that?
It strongly suggests that other genetic factors, maybe common variations called SMPs or environmental factors, are also influencing the final cholesterol level and disease risk. It's not always straightforward.
Okay, so FH is a very clear, often single gene driver of high cholesterol and atherosclerosis risk. But genetics influences other big risk factors too, doesn't it? It's not just cholesterol.
Not at all. Our genes also significantly influence our susceptibility to hypertension, diabetes, and obesity, all major, often familial contributors to atherosclerosis risk.
Let's tackle familial hypertension first. High blood pressure. How does that connect to atherosclerosis, and where do genes fit in?
Well, high blood pressure physically damages the artery walls over time. That constant excessive pressure makes them more prone to injury, inflammation, and eventually plaque buildup.
And it definitely runs in families. People say that all the
They
time.
do, and for good reason. There's a substantial genetic component to blood pressure regulation. Estimates vary, but genetics might account for, say, 30% to 50% of the variation in blood pressure levels between people.
Is it like FH with single major genes, or more complex?
For the common form of essential hypertension, it's generally much more complex. It's thought to be polygenic, meaning many genes are involved, each having a relatively small effect on its own.
And these genes interact with lifestyle?
Exactly. They interact with environmental factors like diet, salt intake, stress, physical activity. It's a combination of genetic susceptibility and environmental triggers that pushes blood pressure up in most people.
Have specific genes been linked to this, even if their effect is small?
Yes, a lot of research has focused on genes involved in the renin-angiotensin-aldosterone system, or RAAS. This system is absolutely critical for regulating blood volume and vascular tone.
RAS, right.
Key genes here include AGT, making angiotensinogen, ACE, the enzyme that converts angiotensin verse to 2, and the receptors A21R and AT2R that angiotensin acts upon. Variations in these have been associated with hypertension risk.
So genes affecting how sensitive we are to salt or how our blood vessels constrict.
Essentially, yes. And also how our kidneys handle salt and water, which is crucial for long-term blood pressure control. There are also rare single-gene disorders that cause severe hypertension, like familial pheochromocytoma, but they're not the common pathway.
Okay, moving on to familial diabetes. The link between diabetes and heart disease is well known. How strong is the genetic tie-in there?
It's very strong. Cardiovascular disease is unfortunately much more prevalent and a major cause of death for people with both type 1 and type 2 diabetes. Type 2 diabetes in particular, which involves insulin resistance, has a clear heritable component. It clusters significantly in families.
How does insulin resistance actually contribute to atherosclerosis? It's not just about high blood sugar, is it?
No, it's much more than that. Insulin resistance triggers a cascade of problems for blood vessels. It can increase reactive oxygen species, ROS, which cause oxidative stress. It decreases nitric oxide, NO, which is vital for keeping vessels relaxed and healthy.
Okay.
It also often leads to higher levels of free fatty acids circulating, which can directly impair endothelial function, the lining of the blood vessels, and promote low-grade inflammation.
Doesn't the body produce more insulin to compensate? Hyperinsulinemia?
Yes, and that high insulin level itself contributes. It can stimulate the liver to produce more VLDL, another type of lipoprotein, increase cholesterol transport and synthesis within the smooth muscle cells of the artery wall, and even promote the proliferation of those muscle cells and collagen production, thickening the artery wall and driving inflammation.
So a lot of interconnected pathways harming the arteries. Are there specific diabetes genes flagged?
For type 2 diabetes, large genome-wide association studies, GWAS, have identified numerous genetic variants, well over 100 loci now. One early important finding was the NIDDM1 locus on chromosome 2q, containing the calpain-10 gene. Another on chromosome 1q was linked to familial combined hyperlipidemia, which often overlaps with diabetes.
But you said these variants often have small effects individually.
That's the challenge. Most of these identified variants are in non-coding regions of DNA and only slightly increase risk. It's likely the combination of many such variants plus lifestyle that leads to disease. Interestingly, many seem to impact pancreatic beta cell function, how well insulin is secreted, rather than insulin resistance directly.
Okay, let's turn to familial obesity. It's obviously a huge health issue. How solid is the genetic link, and how does it feed into atherosclerosis?
The link between obesity and increased cardiovascular risk is now very well established, despite some earlier conflicting studies. Obesity is deeply intertwined with other risk factors. It strongly predisposes people to type 2 diabetes, hypertension, and dyslipidemia, unhealthy cholesterol levels.
So it's a major driver of the other conditions we've discussed.
Exactly. And the genetic influence on obesity itself is substantial. You see it clustering in families. Twin studies show high concordance for body weight in identical twins, and specific genes have been clearly identified.
How much does family history increase risk?
Having a family history can increase your personal risk of obesity anywhere from 2 to 8 times, and the risk is even higher for developing severe obesity. There are rare monogenic forms, but like hypertension, common obesity is mostly polygenic.
What are some key genes or pathways involved in weight regulation?
A major pathway is the leptin-melanocortin system. Leptin is a hormone produced by fat cells that signals satiety to the brain.
Right, the I'm full hormone.
Kind of. Mutations in the gene for leptin, LEP, its receptor, LEPR, or downstream players in the brain like MC4R, POMC, PC1, can cause severe early-onset obesity by disrupting appetite control and energy expenditure signals.
And the large genetic studies, have
Yeah.
they found more common variants?
Oh, yes. JWS have identified many loci associated with BMI and obesity risk, including genes like FTO, one of the strongest associations, SH2B1, KCTD15, MTCH2, NEGR1, BDNF, PCSK1, CTNNBL1, among others. It's a complex network affecting appetite, energy use, and fat storage.
Okay, one more area. Peripheral artery disease, PD. Atherosclerosis in the legs. Is the genetics different there?
PAD is fundamentally atherosclerosis, yes, but affecting the arteries supplying the lower extremities. Clinically, it often presents differently than coronary artery disease, CAD, or cerebrovascular disease, CVD.
How so?
You tend to see less acute events like sudden heart attacks and more progressive narrowing causing pain with walking, called claudication, or in severe cases, critical limb ischemia.
Does that suggest different underlying factors, maybe different genetic contributions?
It's plausible. Perhaps the balance of genetic and environmental risk factors or the specific biochemical pathways involved differ somewhat between PA and, say, CAD.
Have we found strong genetic links for PA?
Honestly, fewer specific genetic variants have been consistently replicated for PAD compared to CAD or lipid levels. This might be because PAD itself is more varied, what doctors call heterogeneous.
Varied in what way?
Well, it can affect different parts of the leg arteries. Proximal disease, higher up, seems more linked to smoking, hypertension, and dyslipidemia, often in women. Distal disease, further down, is more associated with older age, male sex, and especially diabetes,
So different risk profiles for different locations.
potentially reflecting different underlying mechanisms. Some candidate genes have been proposed, like fibrinogen, ApoB, ENOS, MTHFR, IL-6, but findings haven't always held up. There was a linkage study pointing to a region on chromosome 1, but the specific gene isn't confirmed.
But family history is still relevant.
Oh, definitely. People with PAD are significantly more likely to have a family history of PAD. This association seems stronger in younger individuals and those with multiple affected relatives. Twin studies also show higher concordance in identical twins, supporting a genetic component, even if the specific genes are harder to pin down. And certain Mendelian disorders, like FH, definitely increase PAD risk.
Okay, we've spent a lot of time on the genes, but you stressed earlier it's not just genes. Non-genetic factors are critical too.
Absolutely critical. It's almost never just one thing. Atherosclerosis development is nearly always a combination of genetic predisposition, epigenetic modifications over time, and crucial gene-environment interactions.
Let's unpack that. Gene-environment interactions, what does that look like in practice?
It means that the impact of your genes can be magnified or dampened by your environment and lifestyle. Someone might have a genetic profile that gives them a slight susceptibility to high cholesterol. But if they then eat a diet very high in saturated fats and don't exercise, that genetic tendency might be amplified, leading to much higher cholesterol and earlier heart disease than someone with the same genes but a healthier lifestyle.
So the environment unlocks or boosts the genetic risk.
Exactly. High-risk genes in a high-risk environment can synergistically increase disease risk significantly. We see strong evidence for this across CAD, obesity, type 2 diabetes.
And the other piece you mentioned was epigenetics. That's about how genes are expressed, not the code itself.
Correct. Epigenetics refers to modifications to the DNA or the proteins it's wrapped around that change gene activity without altering the underlying DNA sequence. Think of them as switches or dimmer dials on the genes.
Like instructions on top of the main blueprint.
That's a good way to put it. Common mechanisms are DNA methylation and histone modifications. These epigenetic marks can be influenced by both genetics and the environment, diet, toxins, stress, aging.
And these changes can be passed down.
Some epigenetic changes can be heritable, yes. They provide a link between our fixed genome and our changing phenotype or health status. It's thought that epigenetic dysregulation plays a role in the development and progression of cardiovascular diseases, including atherosclerosis.
Wow. So it's genes, environment, and these epigenetic layers interacting. Extremely complex. How then do clinicians actually assess someone's risk for these familial forms and make a diagnosis?
It's definitely a challenge. General risk calculators like the Framingham score or the ACA-ASCVD score estimate overall risk, but aren't designed specifically to capture that inherited component.
So they might underestimate risk in someone with, say, FH.
They could, especially if the person is young and hasn't yet developed other risk factors like hypertension. That's why for specific heritable conditions like FH, we have dedicated diagnostic tools.
Like what?
There are established criteria, such as the MedPed criteria, the Simon Broom Register criteria in the UK, the Dutch Lipid Clinic Network score. These combine LDL cholesterol levels, the presence of those physical signs like xanthomas, and crucially, family history of high cholesterol and early heart disease.
So they systematically look for the familial pattern.
Right. And there's also a broader concept emerging classifying people with severe hypercholesterolemia, like LDL consistently over 190 mg/dL, as high risk, even if a specific FH gene mutation isn't found, because their risk is still significantly elevated.
Let's focus on diagnosing FH specifically then. What are the key steps?
The primary trigger is usually finding those severely elevated LDL levels. After ruling out secondary causes like thyroid problems or certain medications, specific thresholds exist for adults and children.
And then family history is key.
Absolutely vital. A detailed pedigree looking for patterns. In autosomal dominant FH, you'd expect to see high LDL and premature cardiovascular disease in roughly half of first-degree relatives across generations. For recessive forms, parents might have normal LDL, but siblings could be affected.
And genetic testing.
That provides the definitive diagnosis. Usually involves sequencing the main FH genes, LDLR, APO, PCSK9. Newer panels using next-generation sequencing can test many genes at once.
What if the main genes are normal?
Then testing might expand, or sometimes specialized tests looking at cell function or other biomarkers like plasma phytosterols might be needed for rarer conditions. Once a case is confirmed, cascade screening is highly recommended.
Testing relatives.
Yes. Systematically offering testing to first-degree relatives, then second-degree, and so on. It's the most effective way to find others who are affected but might not know it.
Okay. What about diagnosing familial hypertension? Is genetic testing common there?
Not for routine primary hypertension. As we said, it's typically polygenic. While family history is a strong risk factor, hypertensive individuals are about twice as likely to have a family history. We don't usually test for specific genes like AGT or ACE in clinical practice to diagnose it.
So the diagnosis is based more on blood pressure readings and ruling out secondary causes.
Correct. The workup includes assessing family history alongside other risk factors like diabetes, cholesterol, weight, age, smoking, stress. Certain clinical pictures might prompt a referral to investigate rare monogenic forms or secondary causes, but usually not genetic testing for common hypertension itself.
And familial diabetes, how is family history used there?
Family history is a very powerful tool for risk stratification, categorizing someone as having average, moderate, or high risk based on affected relatives.
Does it differ between type 1 and type 2?
Yes. For type 1, while there's a genetic component, certain HLA types like DR3 and DR4 confer risk, it's complex, often needing factors from both parents. A strong family history or early onset might suggest higher genetic loading. Risk can be assessed using genetic markers, autoantibodies, and metabolic tests, especially in research or for relatives of affected individuals.
And type 2?
The familial link is actually stronger for type 2 than type 1, though lifestyle and shared environment also play huge roles. Having one parent with type 2 increases your lifetime risks significantly. Having two parents increases it even more. Twin studies show much higher concordance in identical versus fraternal twins.
But genetic testing isn't standard for predicting type 2 risk.
Not currently for clinical prediction. While GME have found many associated variants, their individual predictive power is small. Family history remains the more practical tool. There are exceptions like MODY, maturity onset diabetes of the young, which is monogenic, and testing is useful there.
Lastly, diagnosing familial obesity. Again, family history seems key.
It's fundamental. BMI is the standard measure for assessment. We know heritability for BMI is high, maybe 70% or more. Even specific fat distribution patterns, like waist circumference or visceral fat, show heritability.
Visceral fat being the dangerous internal fat.
Exactly. That deep abdominal fat is more metabolically harmful. Researchers look at various biomarkers, hormones like leptin, adiponectin, inflammatory markers, but these aren't typically used for routine genetic risk assessment of obesity outside of research or diagnosing rare syndromes. Family history and clinical assessment are the mainstays.
Okay, so we can identify people at high familial risk.
Yeah.
What about management? If you have FH, for instance, what can be done?
The great news about FH is that with early diagnosis and consistent aggressive treatment, often starting in childhood, people can achieve a near normal life expectancy.
That's huge. What does treatment involve?
The primary goal is lowering that LDL burden as much and as early as possible. This improves endothelial function and slows or even prevents atherosclerosis progression. Lifestyle is the foundation. A heart-healthy, low-saturated trans fat diet, physical activity, avoiding smoking.
And medications.
Statins are the workhorse. They inhibit HMG-CoA reductase, lowering cholesterol production, and importantly, causing liver cells to put out more LDL receptors, which pulls more LDL out of the blood.
So they boost the body's natural clearance system.
Precisely. There are specific statins approved for use in children, and doses are carefully adjusted. Often, other drugs are needed too. Ezetimibe, which blocks cholesterol absorption in the gut, is a common add-on. Bile acid sequestrants might also be used.
What about the really severe homozygous FH? Are statins enough?
Rarely. HoFH management is very challenging. It usually requires high-dose statins plus ezetimibe and often additional newer therapies.
Like what?
Mupirocin, an antisense oligonucleotide targeting ApoB, and lamidipide, an MTP inhibitor reducing VLDL production, were earlier additions. More recently, PCSK9 inhibitors monoclonal antibodies like evolocumab and alirocumab have been game changers for many.
Blocking that PCSK9 protein we discussed.
Yes, leading to more LDL receptors. And even newer is evinacumab, which targets ANGPTL3, working independently of the LDL receptor pathway. For young patients with severe HoFH unresponsive to drugs, LDL apheresis, physically filtering LDL from the blood, or even liver transplantation might be considered.
Liver transplant. Wow. And research continues.
Absolutely. Gene therapy and gene editing approaches using technologies like CRISPR-Cas9 are under active investigation, offering hope for a potential cure in the future.
Okay, switching to familial hypertension management. Does knowing it's familial change the approach much?
The core principles are the same as for essential hypertension. Lifestyle modification, diet, exercise, salt reduction, plus pharmacologic therapy to lower blood pressure and reduce stress on the arteries. Standard guidelines apply.
Any nuances?
Well, a doctor might be more inclined to start medication earlier or perhaps be guided by family history. If a certain class of drug worked well for a parent, it might be a reasonable first choice. Some guidelines suggest initial drug choice based on age or ethnicity, like ACE inhibitors for younger patients, calcium channel blockers, or thiazides for older patients, or those of African ancestry.
And combination therapy is common.
Very common. Many people need 2 or 3 drugs to reach their target blood pressure. Common classes include thiazide diuretics like chlorthalidone, ACE inhibitors, ARBs, calcium channel blockers, beta blockers, especially vasodilating ones like carvedilol, and sometimes others like spironolactone or alpha blockers. It's often a stepwise approach.
Are there newer interventions being explored?
Yes, for resistant hypertension, procedures like renal denervation, disrupting nerves to the kidneys, and carotid baroreceptor stimulation are being investigated, but they aren't standard care yet. The goal is always to get the pressure down to recommended targets, maybe even lower if other conditions like diabetes are present.
What about managing familial diabetes, keeping the genetic aspect in mind?
Management requires continuous medical care and a real focus on multifactorial risk reduction. It's not just about blood sugar. Controlling blood pressure and lipids is equally critical. It demands a collaborative approach involving the patient, family, and the healthcare team with a strong emphasis on education and ongoing support for self-management.
And familial obesity. Beyond eat less, move more.
That's the foundation, focusing on sustainable changes in eating habits, increasing activity, reducing sedentary time, often involving the whole family. Even modest weight loss, say 5–10%, can significantly improve blood pressure, cholesterol, and insulin sensitivity.
Is there a role for medication or surgery?
Yes. Drug treatment is an evolving area, used as an adjunct to lifestyle changes for individuals with a BMI over 30 or over 27 if they have related health problems. Several medications are approved. For severe or extreme obesity, BMI 40 or 35 with comorbidities, bariatric surgery can be a very effective option, leading to substantial weight loss and improvement in related conditions.
So wrapping this all up, it's clear that atherosclerosis, especially when it runs in families, is incredibly complex.
It really is. It involves this intricate dance between our inherited genetic blueprint, the presence of associated diseases like diabetes or hypertension, epigenetic factors, and our interaction with the environment and lifestyle choices.
And understanding these familial patterns seems crucial for clinicians.
Absolutely. Recognizing these patterns of hyperlipidemia, hypertension, diabetes, and obesity allows for earlier identification of at-risk individuals and implementing management strategies sooner, which is key to reducing the long-term burden of cardiovascular disease.
So as we conclude this deep dive, what are the key takeaways for our listener?
I think the main points are: 1, your genetics undeniably play a role, sometimes a very large one, in your risk for atherosclerosis via multiple pathways. 2, family history is therefore a really valuable low-congregate risk assessment tool.
Right. Don't ignore it.
Definitely not. 3, even with the genetic predisposition, lifestyle modifications and medical treatments can make a profound difference, especially when started early. And 4, this is a rapidly evolving field. Genetic testing is becoming more accessible, and new targeted therapies are changing how we manage these conditions.
And hopefully for you listening, understanding these connections empowers you. It gives you the language and the context to talk to your healthcare providers about your own family history and personal risk.
It really should. It helps you be a proactive partner in your own health.
Which brings us to a final thought to leave you with. As genetic information becomes ever more available through direct-to-consumer testing through healthcare systems, how might this fundamentally shift our approach to preventing and managing heart disease?
Yeah, that's the big question, isn't it? Could we see a future of truly personalized preemptive cardiovascular care based on individual genetic blueprints, identifying high-risk individuals from birth or early childhood and intervening before disease develops?
It opens up huge possibilities, but also raises significant ethical and practical questions about access, interpretation, potential discrimination. Definitely something to ponder.
Food for thought, indeed. How do we use this powerful information wisely?